Yeah, Eberhard.
Hi, can you hear me?
Hi. Yes, you can start.
Okay, well, thank you very much. And I apologize for the glitch this morning. I don't know what happened, but thank you for having me. Unfortunately, I couldn't join because there's an issue with visa now. And I guess the Indian consulate and even the, the embassy changed their policies. I actually also have problems getting back to India live now with the visa. Anyway, I'm glad that I could join via Zoom and sad not to be there. And Srinivas was kind enough to slightly modify the initial topic. So the actual topic right now that I will be talking about is how can new TAVR valves reduce complications? And I would continue with my financial disclosures. And the ideal transcatheter aortic valve, we all know, doesn't exist at this point in time. We believe it should be durable. It should have a low profile for transfemoral delivery, obviously low complication rates. There should be a simple and predictable deployment, good valve performance, and obviously also minimal interference with surrounding structures. If we look at the next generation THV as we move forward, particularly in the low risk and younger patient group, we have to look for priorities. And I think on this slide, I would like to point the priorities out. We have to optimize the index procedure. We have to extend the valve longevity, very important for younger patients, maintain coronary access, and we should have a plan for THV and THV. How do we prevent TAVR complications? TAVR-related complications can occur at any time from the time of the procedure to years post-implant. An individual patient may be at increased risk for certain complications due to comorbidities or anatomical features. Furthermore, the risk of a given complication may differ by valve type. For these reasons, it is critically important to engage the heart team for case planning and assess each patient individually. Procedures type, size, and access route should be determined on a case-by-case basis. As we all know, we are expanding indications. We find new access routes, as an example here, carotid. We're dealing with failed bioprosthesis. Previous speaker pointed that out already, discrepancies between invasive and echo findings on SVD and BHV. We're dealing with pure aortic insufficiency. We have means to do this now, particularly in Asia. We're dealing with bicuspid valves, and obviously we move into the field of moderate risk aortic stenosis patients. That is the dream, that we have one valve for life. Then we wouldn't have to worry about anything that we are dealing with at this point in time. And maybe at some point, we will have this particular valve. Alternative materials are actively being researched, and this research may address shortcomings of current bioprosthetic valves as shown here. If we look at the valves in 2023, we can say a clinical trial and real-world data show that the new TAVR systems are producing excellent clinical outcomes. They are improving and addressing further conduction, PVL, coronary, and peripheral access issues, so-called lifetime management. By improving deployment accuracy and ease of use, using repositionable systems, continued advancement of those valves with advanced steering, torqueability, depth control, and low-profile materials. And of course, we would like to ensure durability by following up those patients with continued trial follow-up and by using engineering and bench testing with tissue engineering, finite modeling, finite element modeling, and animal testing. The current challenges for TAVR devices, the big five we are dealing with, and some are associated with mortality. And I believe we can summarize we're doing quite well. Mortality came down, bleeding complications came down, pacemaker rates came down, and the stroke rate is not coming down, but it is in an acceptable range. However, hovering between, depending on what data you look at, between 3 and 3.5%. We have many TAVR choices. So how do we optimize outcome with each, and which device is best for which patient? Let us distill the essentials. What determines device choice? Physician preference, company relationship, ease of use, patient anatomy, reduction of complication, and compelling long-term data. No matter the device, there are two keys to optimizing TAVR outcomes and reducing complications: patient evaluation and sizing, utilizing 3D measurements, and the correct implant technique for each individual valve. Each device has its own nuances for sizing and for implant technique. You should understand the specifics for the device that you are choosing. And we all know optimizing outcomes begins with the patient. Anatomical risk factors and CT measurements are mandatory in today's world, and we should choose the appropriate valve in order to eliminate these complications. We're starting with new technology. Evolute FX TAVR system has a redesigned tip and increased capsule flexibility. It does have an optimized stability layer, a single spine shaft for greater shaft flexibility, and enhanced visualization with radiopaque markers to provide a reference for deployment depth and commercial localization. The Edwards Resilia Tissue Valve X4, dealing with the Resilia tissue calcium blocking technology, dealing with the leaflets anti-calcification treatment to ensure longer durability. This valve is being used both in surgery and in TAVR valves. The next in line for TAVR, Actuate Neo 2 and Navitor. These next generation TAVR devices address improving PVL, implant depth control by radiopaque markers, large cells for coronary access, and improved conformability in irregular and calcified anatomies. Definitely increasing momentum, the venous valves, the J valve, and the Jenna valve. The venous and venous A+ valve, solely used in China, is a self-expanding valve with supraannular leaflets, and the second generation venous A+ includes reinforced shaft system to allow retrievability and repositioning. The venous aortic valves outside China, the venous Vita valve and the venous Power X valve, both valves have anti-calcification treated dry tissue, an adaptive foam PU for sealing. On the venous Power, it's preloaded, have short valve frame and large cells for coronary access. The transfemoral J valve has three U-shaped graspers, so-called anchorings, designed to grasp onto native valve leaflets to secure sealing and positioning. The transapical approach has been CFDA approved in 2017. Early American experience have been published recently with good procedural success, no moderate AR at 30 days, hemodynamic profile with very low mean gradients and a very effective orifice area, more than 2 square centimeters. The transfemoral Jenna valve has been approved for aortic stenosis and aortic insufficiency in Europe. It's being used increasingly here in Europe. It does have a unique design for securing and sealing valve in native anatomies. It aligns with native cuffs, commercial alignment by design with locator clips that have a natural seal and stable securement. On the right side, you can see the device has large open cells that provide access to low coronaries. This is a case from my colleagues in Cologne, very successful treatment of massive aortic insufficiency with this particular valve. The Align AR study in Europe and in the United States assessing safety and effectiveness of the Jenna valve has been concluded. The intermediate results show very, very good low mortality rates and a very, very high success rate. This is an interesting summary of the German multi-center study with 95 patients, high technical success, no second valve required, 30-day mortality, low one-digit number, here 1.7%, a moderate and severe aortic regurgitation, no patient. If you look at the lower part, the new pacemaker rates is something that we're learning. Something that we are not learning in this cohort is the aortic stenosis patients, very, very low pacemaker rates in the low one-digit numbers. And as we increase the patient numbers, the low pacemaker rate remains the same. In the patients with aortic regurgitation, we are learning, and even there, the pacemaker rate is coming down from initially 18% now with less oversizing to numbers to high one-digit numbers. I think as we get more experience with this valve, even that number will be coming down. So new technologies that are dealing with leaflets and material sinus innovations is the anterior Duraf, the Foldex valve. The anterior Duraf THV, Sushil has published recent data, a very interesting technology. Here is the summary of the data, and I will try to, start the animation. It does have a biometric design that's shaped for the native performance. It has a low profile, large open cells for coronary access, anti-calcification tissue engineering process, and it is a single piece leaflet design. It is a balloon expandable delivery with commercial alignment. On the right side, you can see great EOAs and low gradients. And here down here, you can see that this might be the first one to show and restore normal aortic flow like in normal valves. The Foldex tri-heart valve with polymer leaflets and robotic manufacturing, mainly used in India, particularly on the surgical valves. The company is moving into the transcatheter field with the design goals of new polymer technology that is engineered to potentially last a patient's lifetime. Maybe our dream comes true. No struts between commissures to impede coronary access. Hourglass-shaped frame, increased space between frame and ostia to adjust certain anatomies. 15mm sealing skirt to minimize PV leak, and electrospun polymer skirt that is enhancing anchoring and ingrowth. And last but not least, something very interesting and something very new. Recently done the first in man, the Valve Medical ZMed modular TAVR system, consisting of a valve module shown here and the anchor module. In the middle, you can see the assembled valve. It does have a 3D piece, one-piece technology, bovine leaflets, and it has a polymer swelling material that once in contact with blood is swelling, reducing PVL, and obviously this valve can go to very, very low delivery catheters. First in man patients being done at Rabin Medical Center by Rand Konofsky and his team. Here you can see the very flexible device, 12 French OD with the catheter in place. You can see the upper frame deployment on the right side as it opens. That is the anchoring module. And then you can see the valve module pre-docking as it is deployed within the ascending aorta and then assembled with the anchoring module. And finally, you implant the valve by pushing slightly forward into the annulus, and then you have this result that's shown on the right side with very, very great hemodynamics in this particular first patient. Congratulations to Ran, who did the very first case some time ago, and on Thursday they will do the second case. So in summary, this particular valve, an ultra-low profile, true 12 French OD. It's a folded valve design. It is not crimped. 3D one-piece valve leaflet construction with bovine pericardium. Two-component hydrogel coating on frame to reduce paravalvular regurgitation. First in man, successfully done and coming up in 2 months, Q4. 9 French equivalent inline sheath system. And you can see on the left side the ZMed 4mm device, comparing it to Evolute and actually in Sapien devices. My final thoughts: the risk for each complication will vary on a case-by-case basis, and all available error information should be weighed to come up with an individualized plan for each patient. The key to mitigating most complications is proper valve size selection and, of course, proper placement. Recapture technology can and should be exploited whenever necessary to ensure the patient leaves the room with the valves in the right location. And I would like to finish with the wise words of our mentor, Dr. Leon. What's hot in the TAVR newcomers and new techniques? The industry leaders continue to iterate and innovate. There's a rapid emergence of other TAVR systems approved in EU, coming to US. New TAVR systems from China are entering the clinical marketplace. TAVR newcomers are developing novel device designs, dry leaflet technology, PVL prevention, and ultra-low profiles. Tissue engineering concepts are quickly evolving and may spark a future round of improved valve leaflet designs. Finally, new techniques for lifetime management and AV remodeling are increasingly being used. With that, I would like to close. Sorry for the glitch before, and thank you very much for your kind attention.
Dear Eberhard, thank you so much for a wonderful overview. Finally, we will have in some years new devices which are modified and probably easier in use. And there is definitely a trend to smaller devices, smoother. So this will probably be associated with a lower rate of complications. So we are very late now, so we have
Okay.
to go. Thank you so much.